Welcome, everyone. And we're just going to give a few minutes for all the participants to join, and we'll get started in just a few minutes. Thank you very much. So as all the participants to this webinar are joining, I just want to welcome everybody on behalf of the United Nations Institute for Training and Research and the Global Surgery Foundation. We're very pleased to be co-hosting this webinar with the evidence-based reviews in surgery, and we'll just be starting shortly. We see that a number of the participants are still signing in. But I think we can get started, and I just want to turn the floor over to both Dr. Neel, Datta, and Chad Ball, who are going to be our moderators. We're very pleased to have an excellent panel and a great topic. So thank you very much. And Chad, can I give the floor to you now?
Thanks so much, Jeff. Welcome to everyone around the world. We're really excited. We'll start with an introduction of our panel, and truthfully, all three of our surgeons today are really master surgeons and master educators. First, we would like to introduce Dr. Keith Lovamo. Dr. Lillemoe has been the president of really every major North American surgical society of note. He is the current and longstanding editor of the Annals of Surgery. He's a surgeon-in-chief as well as the chief of the Department of Surgery at Mass General in Boston at the Harvard University. And I think you've been that for about just over a decade now, if my memory serves correct. And Dr. Lillemoe really is world-renowned in a number of areas, of course, but in particular for this topic today, bile duct injuries, bile duct reconstructions, and really the quality of life measures that these patients suffer or hopefully not suffer after those reconstructions. So thank you for being on the show today. Next panelist is Dr. Magella Doyle. She's currently a professor of surgery at Washington University in St. Louis. She's the director of the HPB Fellowship Program as well as liver transplantation. And Magella is known for giving superb talks and insights on this topic as well as a myriad of others. Finally, and lastly, but definitely not leastly, was Professor Jeff Barkin. Dr. Barkin is a professor of surgery at McGill University here in Canada. He holds advanced degrees in clinical epidemiology and biostatistics. And Jeff is particularly interested in this topic for quite a long time. And I'm hoping that we can gain some of his insight as one of the original members of the SAGES Committee on Safe Laparoscopic Cholecystectomy in the mid 2014-15 sort of era. So welcome all of you, and thank you very much for taking time, particularly from the American Surgical Society. I'm meeting for Drs. Lillemoe and Dr. Doyle. So as many of you know, watching this is the manuscript that EBRS and Dr. Datta have chosen. Safe Cholecystectomy, Multi-Society Practice Guidelines, basically a consensus state-of-the-art conference statement on the prevention of bile duct injuries during cholecystectomy. I thought we would start with a little bit of the history and ask Dr. Barkin for his initial insight here. In 2014, SAGES, which is certainly a North American entity, but increasingly global, developed the Safe Cholecystectomy Task Force to begin looking at this topic. And Jeff, we're curious, how did this initiative begin? And what was the initial sort of sense of the goals and the mission statement?
I always worry when we're asked to talk about history, and again, being asked more and more often to talk about history. I guess it says something about how long I've been around. I think there's a number of people who are interested. SAGES has always been interested. They've been interested in what surgeons do in everyday practice and cholecystectomy. And ever since laparoscopic cholecystectomy came around, the evaluation of laparoscopic cholecystectomy and the evaluation of everything around laparoscopic cholecystectomy, whether it's intraoperative cholangiography, management of acute chole, has always been at the forefront. I think, I mean, it's hard to remember exactly. I wasn't involved right from the start, but I think Michael Brunt decided that he was going to fix this problem of bile duct injury, along with a lot of other people who've been trying, amongst whom Keith Lovamo here on the call, who've been trying to get a hold of this. And he was going to put, I think, the force of SAGES, which is quite a huge association, behind this to try and get it going. And a number of people were involved. The ones I dealt with mostly were Steve Strasberg, Horatio Aspen, and Raj Agrawal also. And I think there was a task force that was put together in 2014, and they started meeting pretty regularly. And a Delphi conference was set up, which led to the first biggish publication on this. And there was a set of videos. I mean, the SAGES has always been very much video oriented. And I think this is a video rich area where you can learn quite a bit from it. And those came out, and then gradually everything, wound up till the 2018 consensus conference, which involved really 5 of the largest societies, certainly that were involved with in North America, and the paper, which is the topic of the EBRS today.
Keith, you're synonymous with safe laparoscopic cholecystectomy, both up front in terms of prophylaxis and reconstruction at the back end. And as Jeff points out, you were involved in this process from the beginning, essentially. What are your memories of the start of it, and how do you see it in terms of evolution over time?
I think Jeff really hit the key points. Mike Brunt was president of SAGES, and as he was beginning his term or during his term, he clearly made this important priority and started working on a lot of things within SAGES and education and getting the message out. But really, the timeline of pulling the organizations together, I was involved with a few of the early meetings where we were talking about the process. But I really give Mike Brunt the credit. I participated as one of the panelists and voters in the consensus conference in Boston. It was held during the American College of Surgeons meeting. And so it was really very well attended, and a lot of good conversation, good discussion, and some strong opinions voiced. So it was a great process, and then really credit to Mike Brunt and the authors for pulling it all together with a very nice manuscript that we were pleased to simultaneously publish with not only Annals of Surgery, but the Journal of SAGES Surgical Endoscopy.
Thank you for that. So this is table 3 in this manuscript we're talking about today, and it outlines the 18 specific questions that this panel decided to attack. I'm curious, Dr. Lillemoe, you've been involved in, I'm sure, an infinite number of consensus statements and consensus meetings, and both formal and informal. How do you go about putting together one of these endeavors? How do you go about selecting participants, and how does that upfront structure appear?
Well, I think you credit me with being more involved. I've been a panelist on several. I'm not sure I've ever really been intricately involved with the planning, but I think what they did here is study the entire breadth of the questions of laparoscopic cholecystectomy, beginning with safe performance of the procedure, intraoperative and even preoperative decision making when it comes to issues related to acute cholecystitis and subtotal cholecystectomy. And then some of the more controversial areas, such as video documentation or photographic documentation of the critical view of safety and the like. So I think they really, it came down to a good, strong group of people from those many societies that had input. And then, as you know, it did end really in the operating room or in the the early post-operative period. There really wasn't any great discussion about the management of bile duct injuries, the surgical management, other than really point 18, which was the referral to a specialty center for management of the injuries. I think you could have probably done a consensus conference for another day on that topic, because it is somewhat controversial along the lines. So, and then, I give SAGES credit. They certainly could have done this themselves, but again, they reached out to so many other organizations and had great representation. As I said, my first involvement was at an HPBA meeting down in Florida, where they got a group together, and it was just impressive. Not only the expertise in the area, but also the expertise of members of the group in terms of running these. And again, I know I hate to name names at all, but Demetrius Stephanidis was very much involved in sort of the analysis of the data and pulling the consensus conference together so that they could really come up with significant conclusions.
Perfect, thank you. Dr. Barkin, I'd like to ask you as sort of the last question here, which is certainly very important in the EBRS format, to maybe comment on the methodology, realizing there's certainly formal and less formal options and a broad variety, but the methodology in creating a guideline like this, as well as in particular maybe a comment on how you deal with disagreement within this context. The paper here is 25 experts who had to show 80% agreement, for example. But how do you describe the methodology and how that applies to this process? Thank you.
Well, the first thing I'd say is that there was just to complement what Keith said, the SAGES was running with the ball, and they then started, running, I would say, with a bigger ball, a more scientific ball. If you look at the original paper that was published with the Delphi consensus, a lot of it was around specific, I'd say, technical details. The questions that they'd asked on the Delphi, which was a paper they published in Surgical Endoscopy in 2015, were around intraoperative team communication, where you start your dissection, debriefing, how do you secure a cystic duct, etc. And they decided to go, I think, in a much more data-driven direction, which is what you're seeing here. So I think when you start your grade consensus conference, because this is according to the grade paradigm, you have to get your questions. And I just wanted to point out that the questions that are here are really centered around questions where you might be able to get some data. In some cases, a lot, in some cases, very little, rather than questions that are truly opinions. And I think that was important, and it was an important change in the way that I think that SAGES was approaching the question. Once you've choose your questions, you then have to evaluate the questions according to the the data that you have available, and make your best guesstimate as to whether the recommendation can be a strong or a weak recommendation. And there are a number of things that you have to watch out for, which affect what's called the certainty around the assessment, which are, classically, if I remember, it's there's bias, imprecision, lack of consistency in the literature, if the data are direct or indirect, meaning they're inferred, and finally the possibility of publication bias, which is a big thing, I think, in a number of the questions here. And then what they did is they essentially had people presented each of these questions to a jury. And I was on the jury with Keith about, at that time at the American College. And then we essentially voted on it. So it's a jury that voted on it in order to be able to get the recommendation that you get. And the end result are the recommendation, which are each of them outcome-based and hopefully as data-driven as they could be. But it's important to realize, unfortunately, that as it is the case very often in surgery, a lot of these are not data driven necessarily. And in particular, when it comes to bile duct injury, and I think Steve Strasberg made this point very, very often, when your rate is as low as it is for any given area, it's impossible. And people did, for example, for intraoperative cholangiography, there were a number of randomized trials to see if intraoperative cholangiogram could decrease bile duct injury, but it's impossible to power your trial. You're talking about, 2-3 events per thousand, a little bit more perhaps, depending on your definition, but it's very, very difficult to do. And so a lot of the data you're seeing here is based on effectiveness data and indirect comparisons.
Yeah, that's very well said. Absolutely. So in the content part of this webinar, our EBRS colleagues thought we should probably pull out 4 or 5 or 6 of maybe the most interesting and applicable guideline questions here on a global basis. Just before we get to that, though, you can see that in terms of the PICO questions and the methodology and the structure here, this group started with just under 3,000 total publications to screen, and really brought it down to 154 once they excluded unrelated and duplicate publications. So certainly a lot of work, as Dr. Barkin has talked about. The first area we wanted to stop on, in fact, is question 1. And it asked the very simple, you would think simple question: should the critical view of safety versus other techniques, traditional techniques, for example, the infundibular technique, maybe as the origin, be used to mitigate the risk of bile duct injuries during laparoscopic cholecystectomy? And the expert opinion recommendation was that they suggest really all surgeons use the critical view of safety for anatomic identification of the cystic duct, as well as the cystic artery and sometimes the right hepatic artery. Before we delve into some commentary from the panelists, I thought we'd just put this figure up so we're all on the same page, that being the obvious anterior critical view of safety with the cystic duct and cystic artery dissected out, and no other major structure re-entering the liver higher up in that window. We'd love to go to you, Dr. Lillemoe, and get your thoughts on potentially the history of the critical view of safety, but also on its relevance in and amongst all those other techniques, some of which were listed in the document, some were not.
So I think really many of the points that came out of this consensus conference, this was probably one of the ones that I thought was most meaningful. Go back historically, again, I would say maybe Jeff touches on it, but I was in the first wave of people who learned laparoscopic cholecystectomy and taught laparoscopic cholecystectomy in 1990 when it came over from France, and then sort of started at places like Nashville, Tennessee, and Marietta, Georgia, and the like. We didn't appreciate the critical view of safety. It wasn't really talked about. We pretty much all did the infundibular technique. But then as an understanding of the nature of most bile duct injuries, and the classic bile duct injury that was defined first by Bill Myers and the group at Duke, and then subsequently other individuals like Larry Way contributed to this understanding, we recognize that most bile duct injuries came from a misidentification of structures. And that it was very easy with the infundibular view, with either how you angulated your retraction, or if you had the so-called short cystic duct, that you could fall into the trap that you are convinced that the single tubular structure that appears to be coming down from the neck of the gallbladder is the cystic duct, and resulted in many cases. I think Jeff quoted the current number, but it's maybe at the peak was 0.5, 0.6%, or 5 or 6 out of 1,000. And Larry Way really pointed out that most of these injuries were indeed misidentification, and that nobody was taking any steps to eliminate this human error from the process. So again, going back to WashU and St. Louis, and I'm sorry Magella isn't here yet, because this really began with 3 surgeons at Washington University, headed by Steve Strasberg, who, in my opinion, has probably made as much contribution to the safety of cholecystectomy as any surgeon in America or in the world. But Steve and then Mike Brunt as a more junior faculty, and Nat Soper published the first paper describing the critical view in the journal JACS in the mid 1990s. And it was a little slow to evolve, and I myself, it probably took me 4 or 5 years before I adapted it, but it is designed, as Chad mentioned, if you get this view as showed on the, particularly on the operative photograph on the right, it's pretty impossible to make the classic bile duct injury because there is no tubular structure that's anywhere near the point where it'll be injured by doing this. And it not only prevents the classic bile duct injury with the division of the main bile duct, but it also prevents those tougher injuries to manage, like when a segment 4 duct inserts into the cystic duct, or some bits of altered anatomy. And it really, I think, prevents against injury that can be caused by the so-called short cystic duct or pseudo-Marizzi syndrome. And so I honestly think it was a huge advance. The real issue comes down to, what does it mean to not get the critical view of safety? And there's a lot of issues when we talk about bile duct injuries, and I don't want to open this whole Pandora box, but first and most importantly is the care of the patient and restoring biliary continuity and preventing further problems like cholangitis, recurrent stricture, biliary cirrhosis, all those things that can develop with a mismanaged bile duct injury. So ultimately, you want to prevent anything bad from happening to the patient long term. Second, of course, is the short term consequences. People come into the hospital with the thought they're going to have a hour and a half operation and go home in 4 or 5 hours, and subsequently be back the next week, back to work or back to taking care of their families or whatever it might be. So there's the short-term ramifications. And then there's the so-called second victim of the procedure, of the injury, and that second victim is the surgeon. And unfortunately, in the United States, I can't speak globally, and I can't necessarily speak for Canada as well, but bile duct injuries continue to be one of the major causes of medical malpractice filed against a surgeon. And we've done an analysis of our own database, and there is a still substantial number of surgeons who are found to be liable for malpractice or fall below the standard of care in creating a bile duct injury. And the issue often comes down, and I've had the opportunity, unfortunately more times than I'd like, to participate in medical malpractice defense cases. And if the surgeon hasn't dictated the critical view of safety as a step in their lap chole, that's the first thing that the plaintiff's expert will point out. And out of curiosity, I took the sort of the prerogative of a journal editor, and I asked Steve Strasberg to write a sort of an op-ed piece for our journal, Annals of Surgery, on that exact question: should the critical view of safety be considered the really a part of the of the standard practice that is necessary and acceptable as required by the state of the art or standard of care. And this actually, that editorial actually came out before this consensus conference. And Steve was very politically conscious of it. He said, for something to be viewed as the standard of care, it has to be practiced by the majority of surgeons in the field. And he said he wasn't really sure if it was widely practiced. And therefore, it certainly was not at that time considered in his opinion, the standard of care. But to be honest, I think after this strong wording in this consensus conference, and I think most of us who teach lap chole to residents, I think most of us teach it that way. I fully believe that at some point the critical view of safety will be considered the standard of care for safe cholecystectomy, which implies, at least from a medical negligence perspective, that if you don't do it, you will have a hard time explaining why. So I'm sorry that was a little bit of a long-winded answer, Chad, but I think it puts into perspective how I view the value of this technique.
Yeah, I think most of us would certainly agree that was great. Dr. Barkin, I was hoping you could comment on question 2 as our next stop on the pathway here, which was
Can I make a comment, Chad?
Oh, sure,
do you mind? Since you told us you want a little bit of discussion and so on, I agree totally with Keith's comments before. One thing that's always been a bit of an issue for me, and it's not well defined in here, is what really makes the critical view of safety? What are the principles of the critical view of safety? Because if we're going to put it on a high platform, like, let's make sure we know what we're talking about, okay? And, you know, some areas such as the Tokyo guidelines, the latest Tokyo guidelines, you know, go into that a little bit. And there are a number of things that you want to do, you know, because sometimes, Chad, what you'll call critical view of safety is not my critical view of safety. So I think that, you know, there's a few criteria, you know, that you have to dissect enough of the gallbladder off the bed. Usually we say about 30%. You have to make sure that you have the critical view of safety from the front and the back, as you said, Chad. You got to make sure that your dissection started anterior from Revier sulcus. And I think there's a few things that you have to add in order to put it in perspective. The other thing that I'd like to say is, and it's commented in the paper, that the critical view of safety cannot be achieved in every patient, right? In about 5 to 10%, probably I would say 5, but then maybe you're not able to achieve it. And so, you know, what do you do then? And I think the idea is, and I think Steve does say that, the critical view of safety, although it's a technique, it's a little bit of a test, which tells you, aha, you know, I might be in trouble here. And so you pay extra attention, and you're more attuned to the other measures that you can use in order to help you remain as safe as you can. And your threshold for going to something, you know, ultimately like a bailout, starts going a little bit higher at that point. So I think the concept of a technique, but also a test, is useful when you're going in a, you know, in a difficult anatomical situation.
That's
Again, Chad, you can say stop whenever you want to move, because I know you have an agenda of questions, but I think this is an important one. Jeff really stated that beautifully. And in fact, it cannot be a bailout to just dictate in your operative note that you obtained a critical view of safety. Again, speaking to an international audience, I have to be a little careful, but I believe one of the European countries, I believe it's the Netherlands, actually requires photo documentation of the critical view of safety be entered into the operative note, you know, in order to document that you obtained it. And Steve has written on that topic and published on it in you know, the value of it as well. So I think, again, this is about as pretty a picture as you'll ever see of the critical view of safety. I would agree with Jeff. I wish all mine looked quite that good, but again, photo documentation is the absolute gold standard in terms of proof that you obtained the critical view of safety.
We did vote on it, eh, Keith? I mean, it was turned down, as I remember. As
yes,
one of
it was turned down, and you know, I think it was turned down in part because of you know, some of the technical aspects of it, but in part, I think, because I believe the group did not want to create as a strong recommendation or a so-called standard that you know, puts surgeons at a little bit more medical malpractice risk. So
that's a great conversation. The picture, the operative picture on the right of the screen there is a gallbladder from Dr. Datta and Dr. Ibbotson. As you can see, our masters at creating that critical view. If we move on to question 2, then the statement, the question was, should the fundus down or top down technique versus a subtotal cholecystectomy be used to mitigate the risk of a bile duct injury when you cannot achieve the critical view of safety during a lap chole? And so sort of some of the meat and potatoes of I think what's been inferred in your initial conversation. The recommendation then was that the critical view, when it cannot be achieved and biliary anatomy cannot be clearly defined by any other methodology, including intraoperative imaging, we suggest surgeons consider a subtotal cholecystectomy over a total cholecystectomy with a top-down approach. So just to be clear, I think what we're talking about, we don't have to get into the weeds about fenestrating versus reconstituting subtotal cholecystectomy, but this is Dr. Strasberg's paper. We've heard a lot about today, taking part of that gallbladder down, stopping at a point before you get into trouble, more dense adhesions towards the porta hepatis, and in some cases leaving it open, in some cases closing it. So that's the context. Dr. Barkin, I'm curious what your thoughts are with regard to this question and recommendation.
Well, I think there's we're getting into a little bit less data than we've had in some of the areas, so it's have to be a little bit tricky. I think the subtotal cholecystectomy, I think Keith said before, the importance of the critical view of safety is one, and I think the other big deliverable from this paper is putting the subtotal cholecystectomy as an important technique, which does not mean that you'll, and I got to be careful to remain politically correct here, but it doesn't mean you have no hair on your chest if you've done that, okay? It is an appropriate way of going and dealing with the problem. It is not a personal failure that you can't get the gallbladder out, which had still been, I think, a way that some people think, that we think as surgeons, or even in the way that we've been trained. Now, so the issue about the top down, sorry, one more thing about the subtotal is there are technical issues related to the subtotal. I mean, I don't know that we're going to discuss them, but again, the way that I look at it, one is the reconstituting, as Steve Strasberg points out, is not a good idea. You're recreating a small gallbladder, basically. Plus, it can be difficult to close it completely. And the second is, which isn't mentioned here, is you got to make sure you cherry pick all your stones out. If you don't cherry pick the stones out when you're doing your subtotal, you're essentially recreating a hell of a mess for the person who's going to have to go back in when the patient gets symptomatic again to do the second phase of trying to get the stump out, as most of us have been seeing, I think, over the past few years. So this being said, to address your question of the top-down versus subtotal, I think the top-down is something that is a little bit left over from the open surgery. I mean, we used to do top-down. If you couldn't go directly into tiger country in the Calais Triangle, you'd go top-down, try and go at it. And the evidence that is against the top down, and I think Steve Strasberg has published on that, a very dramatic, it would be, I don't know if you call it case control, it's not really a case control study, it's more a series of horrific vasculobilious injuries related to the traction and the scarring when you've done the top down and you're trying to go in. And so that instead of staying in the plane and going from anterior to posterior conceptually between the gallbladder and liver bed, you're actually going down into the liver pedicles, and you're getting an injury where it is not fixable anymore, at least not by me. Keith may be able to fix it, but these are horrific injuries. You get into second order ducts and so on. And so I think based on that concept, in part, the top down has, it's been suggested that it may not be an automatic safe way of doing things. Whereas the subtotal, if you just say, I'm not taking most of the gallbladder out, I'm going to take the anterior wall out, I'm going to cherry pick the stones out, and I'll kind of try and have a peek and see if I can see the cystic duct at the bottom, but I'm not going to put any stitch near a Macamoyle's shield or anything like that down in there. It seems to be a safer way, which is applicable to more people. So I certainly agree with this. And as I say, though, it's based on a little bit less evidence.
Chad, if your hope was to get controversy and disagreement between Jeff and I think we're going to fail you. But I just have to reinforce what Jeff said. Again, being at the stage of my career when I transitioned from doing nothing but open cholecystectomies during my residency to learning a lap chole as a junior faculty member, I had the skill sets to do tough open cholecystectomies. And fast forward now, literally to the history of lap chole now, we're approaching 30 years, the 90s, 2000s and 2010s. And there are generations of surgical residents who have lacked that experience in doing tough open cholecystectomies. And what I have said in talks that in my mind, if you can't obtain the critical view of safety, as Jeff said, and those bells and whistles go off that this is going to be a tough case, and you say, well, the old technique was, well, you convert. And most of us still write into our operative consents. One of the risks is the need for open cholecystectomy. Well, frankly, in my opinion, with all due respect, again, not to offend anybody who's trained since 2000, but the open cholecystectomy in the hands of the current surgical training program graduates, is a very dangerous operation because, again, as Jeff so nicely stated, if you lose the right plane and you just keep expecting to start funneling down with the dome down technique, you may funnel right into the common hepatic artery, the portal vein, and really just major disastrous levels injuries. So I think whether the right term for this is the bailout, which can be accomplished just as well laparoscopically as open, but recognizing that it's time to come back and it's time to, as I said, bail out and not try to tackle this tough, inflamed, particularly chronically inflamed process that could lead to these major injuries. To have this tool of subtotal cholecystectomy in your toolbox is really the safest out. And since it can be accomplished laparoscopically as well as it can be open, again, the patient doesn't have to go through the incision, and the surgeon who's trained since 2000 or even 1995 doesn't have to call on skills that they really haven't done much of. So I think this was, again, a very important statement because it really said you don't have to take that risk to take out the whole gallbladder, and that this is a suitable alternative.
Yeah, but I mean, both of you guys have made some really important pearls. And I think we're going to come back to the conversion conversation again briefly. Question number 4 that was addressed was surrounding intraoperative biliary imaging. Really, I think, in terms of a commonality would be intraoperative cholangiography, although ultrasound was certainly discussed as well in the hands of some that are trained to do so. So should intraoperative biliary imaging versus no intraoperative biliary imaging be used to mitigate risk of bile duct injury during lap chole? And the recommendation was in patients with acute cholecystitis or a history of acute cholecystitis, the panel suggested liberal use of intraoperative cholangiography to mitigate the risk of bile duct injury. Now you can see that's a conditional recommendation with a very low certainty of evidence, as Dr. Barkin points out in some of these comments and questions and recommendations. It says surgeons with appropriate training for lap ultrasound may find that as helpful as well. The second part of the statement at the bottom there, you can see in patients with particularly uncertainty of biliary anatomy or suspicion of bile duct injury, we recommend intraoperative biliary imaging as well, again, to mitigate further risk of bile duct injury. If we come back to you, Dr. Lillemoe, what are your thoughts on this double recommendation?
So I guess I will show my ignorance a bit here. I'm not the most high-tech person to talk about this. Your standard intraoperative cholangiogram does involve typically making a hole in the structure. And if you're totally lost as to what structure that is, even trying to do an intraoperative cholangiogram can create some degree of a bile duct injury. It usually minimizes the extent of injury. So from that perspective, I've never been a big fan of routine use of intraoperative cholangiography as a simple fluoroscopic radiologic technique. Now, the alternative is to inject dye into the gallbladder, and in some cases, you'll see the cystic duct and the contrast flow into the bile duct, but in many cases you won't. So I really think the answer to this is not just your standard old, and by old meaning it's something I practiced again early in my career of intraoperative cholangiography, but some of the newer techniques of imaging, and I've never really had a lot of experience with ultrasound, and if Chad or Jeff have more experience, they could speak to it. But I think the new fluoral contrast agents in assigning green and things like that, and again, for someone who has not embraced robotic surgery, I won't say I didn't embrace it, but certainly not trained in robotic surgery. I mean, one of the things that they're promoting now for robotic surgery, which again really came after this consensus conference, is the ability to use the robot and various dyes to define the biliary anatomy. So I think, like a lot of things, if we had a technique that could really give us the pure anatomy that we want to see, it would be very helpful to have. There's always cost and time considerations, and who do you do it for and who do you not bother doing it for. But I think that this is where new technology is lacking, and I hope at some point during the course of this, we could talk a little bit about some of the work that Dan Hashimoto has done at our place with video review and trying to set off sort of the electronic recognition or the video recognition of injuries that sort of relate to how a Tesla drives into, that's what you're driving now, Chad, isn't it? But so the bottom line is, I think technology will eventually get there, but at least the standard intraoperative cholangiogram, I think, falls short.
That's great comments. Yeah, Neel.
Chad, so for the general surgeon like me who doesn't use intraoperative cholangiogram regularly, the liberal use in a hard gallbladder, do you think that would give you the false sense of security with your anatomy? Because we, as general surgeons, aren't seeing that biliary anatomy nearly as much as our hepatobiliary colleagues. So what's the likelihood that the average general surgeon would fire an intraoperative cholangiogram and misdiagnose or misassess that ductal anatomy?
That's a really interesting question. And as I'm sure you know, there's a reasonably, maybe it's a bit dated now, but a large host of literature that blinded interpreting general surgeons with cholangiograms, and their ability to accurately evaluate those cholangiograms that they had shot was only about 50-50, sort of like flipping a coin in general. So there's the interpretation side of it that you bring up. I'm curious, Dr. Barkin, that's a great question. What are your thoughts?
Yeah, I mean, it can be an issue. I mean, I'm biased. I do ERCPs, so I look at a lot of that. I think as we do more and more MRIs, MRCPs, and I think people are doing, them. I always look for, an excuse in someone who's got something going on for maybe doing an MRI. Billy's a little bit high, get an MRCP out of it, and it's like your pre-test cholangiogram type thing. You get an idea, maybe not exactly the anatomy, but at least you'll have some idea if there's a gross abnormality. There is level 1 data for near infrared light use for cholangiography, suggesting it's superior to white light. There was I think at the time that this paper was written, the trial was going on, the randomized trial was going on. They didn't have the results of it yet. So that's something that I have zero experience with it. That's something that may have some advantage, and it's particular in being able to really decipher the whole biliary anatomy. You're not really looking at stones. You have to realize that in the past, we were mostly looking for stones, right? That was what everything was being done. And although we wanted to make sure that your bifurcation was seen and your duodenum was seen, we didn't sometimes overfill to the point that you would see the whole anatomy. So this near infrared tool might be useful because it's actually not, in my understanding, it's mostly, the endpoint is mostly the anatomy rather than are there stones present in the duct.
That's very interesting. Let's move on to our next question that was addressed, which surrounds the timing of cholecystectomy for acute cholecystitis. So the question is, should immediate cholecystectomy, as defined within 72 hours or 3 days from the onset of the attack, versus delayed cholecystectomy be preferred? And then as you can see, they divided delayed cholecystectomy into 3 groups, basically 3 days to 10 days, 6 to 12 weeks, and then greater than 12 weeks. The recommendation at the end, again, conditional recommendation with a very low certainty of evidence, is that patients presenting with mild acute cholecystitis should undergo their operation within 72 hours. Beyond that, they weren't willing to comment. Dr. Lillemoe, you've certainly written and presided over a lot of annals manuscripts that surround this from around the world. What are your thoughts?
You know, there are so many things in surgery that have just been passed down from generation to generation, and this is certainly one of them, without, as they note, with not a lot of evidence to support it. Yeah, I think, to be totally honest, most decisions now that are made about the timing of cholecystectomy are made because people are anxious to get people in and out of the hospital as quickly as they possibly can. So there's very little delay in management. I think my feeling is again, as an older generational surgeon, is that early cholecystectomy for acute cholecystitis does seem safer. The inflammation isn't as fierce. And I think one thing that has really changed over the course of the last, I guess you maybe would say 5 years, and probably in the midst of when we were doing this, is really the frequent use of percutaneous cholecystostomy. You know, as I see presented from our acute care surgeons, you know, any patient who comes in, you know, in the 7 to 10 day period of time, and at that time has either ultrasound or CT evidence of a big inflammatory mass, it isn't a matter of if they do a cholecystectomy or not. It's they do a cholecystostomy, and again, that creates a whole new set of problems for management at the ultimate time when you do have to operate on the patient. But still, I think sort of lost on this discussion is, what do you do during those delayed periods of time? And I think the role of percutaneous cholecystostomy has really evolved this substantially over the last 5 years.
It's interesting. Dr. Barkin, how do you use tube cholecystostomy, and how do you teach surrounding that?
I think there are 2 points I'd make relating to this, because the issue is exactly as Keith said, I think, is, you know, what are you going to do to these patients? All right. The first point I think I'd like to address is, you know, in our system, sometimes it's not as easy to get the patient to the OR. They wouldn't accept, for example, that an acute chole should have the same level of acuity as an acute appendix, you know, and I beg to differ. You know, I think that these patients should go to the OR, whether you're saying the ideal time is the 72 hours, 4 days, whatever. There is an ideal time, which is earlier, you know, and we know from a very large study in Toronto, based on emergency room visits and admissions, that if a patient comes in and is cooled down, even if that patient is an operative candidate, those patients, when you go back to operate on them, meaning you didn't just not operate because they weren't operative candidates, they were operative candidates, they have an increased risk of bile duct injury when you go back. Okay, it's double, you know, your risk for having cooled those patients down. Now, it's medical admin data, it's, you know, it's contaminated, but we know that there are risks with that. Now, you know, regarding your question about the tube, I mean, we do have the cholecystostomy tube. I think, as Keith said, we have a epidemic of cholecystostomy tubes. And if I see someone who's a 40-year-old woman who had a cholecystostomy tube put in with no comorbid factors, I really don't know that that person's been helped, you know, by anything. And we see that, you know, occasionally. The chocolate trial is level 1 data suggesting that, you know, that it's probably inappropriate, although the population that they looked at in the chocolate trial is a little difficult for me to interpret, because they used Apache 2 scores to stratify the patients. And we don't usually calculate those as is. But basically, unless they're super ridiculously sick, they seem to do better. And they do better, one, because they have well, mostly in that trial, because they have less tube problems. Tube problems from cholecystostomy is not unusual. These tubes fall out, they misplace, they whatever. And so that I think surgery, and I think it's a little bit intimate in this question 8, earlier surgery as early as you can get, because it will be better for you and for the patient. Doing the surgery will reduce your chance of getting bile duct injury later on. And unless it's a Tokyo grade 3, if it's a grade 1 and even a little bit of grade 2, although there's an increased risk, the patient will do better with that. So I think, we should try to get away a little bit from the cholecystostomy tube and save it for, people it was really meant to be for, who are most often people who never make it to cholecystectomy at all.
Dr. Barkin.
I think the decision to do cholecystostomy decades ago were on those patients with the comorbidities, the post-op, I'm getting into a board question here, but the patients with post cardiac surgery cholecystitis, the answer in many cases was do a percutaneous cholecystostomy. Now, I think the decision, as Jeff implied, is not based on the severity or comorbidities of the patients. It's people look at this and say, oh, that's a tough gallbladder, I don't want to do that, and they'll just stick a tube in and then send the patient home and hope that it'll be easier to do in a few months. But the problems of taking care of those tubes, the tubes falling out, and again, in the younger, more fit population who just happen to have acute cholecystitis, that problem's not going to go away like it is in a 90-year-old who you may never operate on. You're going to have to deal with it at some point.
Dr. Barkin, one of the things you just mentioned was, at your institution in Montreal, that challenge of getting these acute cholecystitis patients in. And I suspect that that's something that's a problem everywhere. Recently, our CMPA, our Medical Protective Agency for Medical Liability in Canada, reviewed a whole bunch of medical legal cases around gallbladders. And one of the things they noted was a higher rate of medical liability, or at least lawsuits, when gallbladders were done through the night. And I suspect what's happening is, just as you said, it's hard to get these patients in, so we have general surgeons operating on them late at night. Can you comment a little bit on that, the urgency of getting them done, but also doing them through the night?
Well, I think we're talking about acute chole here, obviously, and I do liver transplants as part of my practice. I do ERCPs, I do hepatobiliary, liver transplants, and we still do a lot of liver transplants. I just did one last week at 2 a.m. You start at 2 a.m, and I just commented again on how, is there a worse time of starting, a case than 2 a.m, if there's any way that you can change it. So these gallbladders, the problem is, and they can be horrific cases, right? Those are the bad ones, the ones that were on the list today, they didn't get done. They're on the list tomorrow, they didn't get done. So you say, oh, well, 3 days later we'll do it. You're down, you're 5-6 days from the acute chole, and you're saying, gee, I got to get it done. I think what we've tried to do here, and it has not worked well, is to say that this is an emergency case and the patients will do better. And we try to use the argument that our administrators use, which is basically the patient will stay in the hospital less and have less complications, not hang around if you let me do it earlier. But it isn't always easy to get them done. Having said this, that's not an excuse for putting a cholecystostomy tube in my mind, and especially we have level 1 data to suggest that's not it. So I think it is difficult. I think you have to advocate for your patient, push it through, and if you can actually get it recognized as a true, category case, a category 2 case that we would have here, then I think you're on more solid ground to say, okay, we'll go ahead and do it.
So Chad, there was a question in the chat. I don't know if this is in the Q&A, if this is a good time to tackle it. And it relates to the use of intraoperative cholecystostomy during lap chole. And again, it's like many things, as IR has gotten more involved with the care of our patients, it is a technique that I think has been lost. The problem with a cholecystostomy tube during done at the time of a lap chole is at what stage do you try to do it? I mean, if you just get in right away and you look at it and say, well, I'm not going to get this out and I'm going to put in a cholecystostomy tube, that's probably a good bailout technique at that point. But, after you've started doing some dissection and after you've started, grasping on the gallbladder and again, depending on the thickness of the gallbladder and the level of inflammation, perhaps even torn a hole in the gallbladder, that still does happen to many of us. The question is, when have you gone too far to be able to salvage with a cholecystostomy? So getting back to the question we had before, I think that the intraoperative placement of a cholecystostomy tube has probably been replaced by the subtotal cholecystectomy in most experienced, and I won't say HPB surgeons, I'll say mostly acute care surgeons, because in general, they're the ones who are doing it.
That's a really important comment. We've talked about so many of these questions inadvertently in this great conversation. I'd like to just finish it with this one and come back to you, Dr. Lillemoe, because you've certainly published as much as anyone in the world on this concept, which is for patients with a bile duct injury during a lap chole. The question was, should the patient be referred to a specialist with expertise in biliary reconstruction, or should it be done by the operating surgeon? I think we all know that, and you've very superficially made some comments to that. And again, as I mentioned, published more than anyone else in the world. Could you comment on the referral concept, the quality of life trajectory thereafter, and really anything you think is relevant? Thank you.
So the answer is to this question, I think it is a strong recommendation. Yes, regardless of the certainty of the evidence. Having cut a bile duct, it's a tough thing to realize. And no matter how good you are or how experienced you are in doing biliary reconstructions, there are a lot of things that are flashing through your mind, and it can influence your decision making. It can influence your conversations with the patient. So I honestly say, if you're in a situation like either an academic medical center or a big enough hospital where there are experienced surgeons who do biliary reconstructions as part of Whipples or do liver resections or even transplants, the common general surgeon, and I am in my mind a common general surgeon, if you create a bile duct injury, I think the wisest thing to do is get help. And if that's the senior surgeon in your own institution, that is probably fine. And I really, it doesn't matter what I'm doing, what meeting I'm doing, unless I'm in the operating room myself, I will drop everything I can to go to the operating room and help a young surgeon in that situation. And so will our transplant team, and so will some of our other HPB surgeons. And that help not only gives you the peace of mind that you've done what's best for the patient, you've had the right sort of unaltered judgment in making the decisions. The classic decision is, well, I think I can just honker these two ends of the bile duct together and not have to do a Roux-en-Y. We all know what happens in that case. If there's been a significant injury and a segment resected, it's going to develop a late stricture. So the bottom line, just to have somebody tell you to do the right thing is important. And then just whatever little techniques and tricks that somebody who's dealt with these before in many settings can bring, how to do your anastomosis, how to drain your anastomosis. If you come from my legacy, how to use intraoperative stents in these cases. Those are the tricks of the trade that, your average surgeon who may cut one bile duct in the course of his or her life won't have in their in their bag. So bottom line is, yes, help right away is important. If you're in a situation where that type of help isn't available, I have been called, by a surgeon, both in Indiana and in Massachusetts, in the operating room. What do I do? I'm sure I've cut a bile duct. The right answer there is, well, If you're sure you've cut a bile duct, stop. Don't try to do anything else. Don't try to take the gallbladder out. Just make sure you control whatever leak might be there, and awaken the patient and transfer the patient, and let that be my decision of how I want to operate. Do I want to get preoperative imaging? Do I want to do a PTC or an MRCP? I think that's important. And really, I do believe there is more than ample evidence. Some of it is old, but others that just makes sense, that having somebody who sews bile ducts together for transplants or for cancer cases has got to be able to provide a better long-term result for the patient that they will have than if done by someone who's never done it before. And again, I hate to make this about medical liability, but two things. Number one, if I make the decision to get a senior surgeon or transfer the patient to another hospital, my possibility of doing more things wrong ends. So if the patient has a complication or whatever, yes, it may be indirectly related to the injury that I caused, but it really isn't my judgment or my technical issues that are at fault. It really is in the hands of the person who I've referred the patient to. And secondly, it is a very tough answer to say to a jury or in a deposition when asked, you've repaired your own bile duct injury, and you get asked, and the patient didn't have a good outcome. They leaked, they had to be transferred, they had some sepsis, they had to have a reoperation or whatever it might be, and you as as the defendant get asked, well, doctor, how many of these bile duct reconstructions have you done? And typically the answer is, well, I did one or two in my residency, and I haven't done one in 10 years of practice as a acute care surgeon, or as a as Neel said, a colorectal surgeon taking an ACS call or the like. So I think for both the patient's benefit and for the surgeon's benefit, getting help is the most important thing. And Chad knows my practice. That's my belief, no matter what I'm doing. If I've got a hole in the portal vein, I've never been embarrassed to call a transplant surgeon to help me put it back together. Or if I need to do a vein resection, when you create an injury, your ego has to be put aside and get all the help you can get.
Well said, Dr. Barkin. I think we'll close with your thoughts, and thank you to both you and Dr. Lillemoe for being on the panel. And once you're done, we'll flip it over to Neel.
I have no thoughts. I recognize Keith as the utmost authority on how you repair bile ducts and how you gain back the quality of life, or hopefully that these patients ultimately lose. A paper in the past I remember reading, I was always dramatic. The quality of life that someone who's had a bile duct injury, as a population, is akin to someone who's incarcerated. And I think that this is something you have to remember. I think, as you said, you get help, you get a second person there, you drain and you transfer.
That was excellent. I want to thank all of our panelists, but also our co-moderator, Dr. Ball. All three of you gave such incredible advice and expertise on this topic. So I think this was a very successful EBRS Unitar webinar. Thank you very much, Dr. Barkin, Dr. Lillemoe. And I'll transfer it over to Dr. Ibbotson.
Thanks, Neel, and thank you for a great discussion. It just brings back so many memories of those 2 a.m. tough gallbladders, and the advice given is excellent. So thank you very much for a great discussion, and we look forward to future discussions with upcoming EBRS webinars. And I just want to make a point here. In looking at all the participants, we actually had participants from all over the world, people from Nepal, from the African continent. And we really want, as a consortium with EBRS, Unitar, and the Global Surgery Foundation, to take this to the next level of taking these discussions globally, and to include the challenges that are occurring in other countries as well. So I really want to encourage you to watch and keep the updates, watch the updates for future events, because we want to expand this to the global scene. So thank you once again, both Chad and Neel, for moderating this great session. And thank you for our speakers. Excellent discussion. And with that, I'll close the session. Thank you very much. Have a great day and keep safe. Thank you.
Bye-bye.